these are for the macular diseases. Let's like take a deep breath and dive into the fundus dystrophies. Okay, so fundus dystrophies, starting by the most important, which is the retinitis pigmentosa. Retinitis pigmentosa is considered like, you see, for each topic there is a most important disease. For vascular diseases, the most important is diabetic retinopathy. For macular diseases, the most important is age-related macular degeneration. And for the fundus dystrophy, the most important is retinitis pigmentosa. So what will be the pathology and the epidemiology? Genetics here plays a very, very important role, like the age of onset and the rate of progression, whether this patient will have a stable progress or he will severely deteriorate, and whether he will be blind like by 30 years old, or he would have like a satisfactory vision his entire life. All this will depend on the mode of inheritance. So mode of inheritance here is very, very important. Most of cases, or in many cases, there are many genes are identified that are responsible for retinitis pigmentosa. One of these genes is called the rhodopsin gene. So the mutation for rhodopsin gene can result in different kinds of retinitis pigmentosa. So what are the genetics? Here, please concentrate. Autosomal dominant retinitis pigmentosa has the best prognosis. The best prognosis is with autosomal dominant retinitis pigmentosa. The sporadic form, where there is no identifiable inheritance pattern, has a good prognosis. Those patients can retain good vision until the 6th decade. Now let's move to the worst prognosis. Autosomal recessive has a poor prognosis, and X-linked recessive has the worst prognosis. Unfortunately, it is the least common. It will cause blindness between the 3rd to 4th decade. Okay, so to remember it, remember Dr. X. Who is Dr. X? Nobody knows, but it's just a mnemonic to remember. So moving from D to the X, it will be the disease will be converted from the more common and less severe and later onset and the better prognosis to the reverse. So the dominant will be the most common, the less severe, the late onset, the better prognosis. The recessive will be the less, and the X-linked recessive will be the most severe and least common and earlier onset with worse prognosis. Okay, so what are the clinical features of retinitis pigmentosa? There is a classic triad for retinitis pigmentosa. The classic triad is the presence of or those patients mainly complain of, or what will be the complaint of those patients? Those patients will complain of nyctalopia or night blindness. So the disease starts first by night blindness. Then as the disease is progressing, they will complain also for blindness at the daylight. So this depending on the stage of the disease. What is the classic triad of retinitis pigmentosa? It will be classified, or the first one, it will be the arteriolar attenuation. So you will find that the arteries are attenuated or very thin. And bony spicule pigmentations, there will be clumps of pigments resemble the bony spicules which are present in the histological section. So this is just a histological name, because it doesn't have any relation to the bone. There is no bone in the retina. It's called the bony spicules. These bony spicules are usually perivascular. They are arranged around the course of the vessels, and there will be like like a gliotic disc, or there is a yellowish optic disc with pallor. This is the third thing. Okay. So this is called the classic triad, and all other features of retinitis pigmentosa can be also classified into triads. So the classic triad is the bony spicule pigmentation, arterial attenuation, and waxy pallor of the optic disc. The posterior segment changes are also in triad. There will be optic disc drusen, posterior vitreous detachment, and myopic degeneration. For the macula, there will be triad, like cystoid macular edema, epiretinal membrane, and atrophic degenerations. In the anterior segment as well, it will cause triad of keratoconus, open-angle glaucoma, and posterior subcapsular cataract. Okay, so just let me tell it before I forgot. If this patient with retinitis pigmentosa developed posterior subcapsular cataract, okay, so should we treat him or not? He already has retinitis pigmentosa, so he has already poor vision. So should we give it a try to manage it or not? The same thing happens with the cystoid macular edema. If a patient has retinitis pigmentosa with cystoid macular edema, should we treat it or not? According to the evidence, well, it should be treated. So if a patient has cystoid macular edema, it should be treated. If there is posterior subcapsular cataract, then the cataract should be treated. It was found that they will gain some benefit from treatment. Okay. So of course, the retinitis pigmentosa doesn't have a treatment, despite just the treatment of those complications. But we need to identify if the retinitis pigmentosa is a part of systematic disease or not. So we can manage other associations that this patient could have. So this systematic associations are called the syndromic retinitis pigmentosa, in which the retinitis pigmentosa is a part of syndrome. These syndromes are commonly asked in the exams, so let's see what are the criteria for each syndrome. One of the commonest associations or commonest syndrome associated with retinitis pigmentosa is called the Usher syndrome. In Usher syndrome, it is famous for presence of deafness. They will have blindness and deafness, and it runs in families. So it will be autosomal recessive disease with sensory neural deafness, most commonly congenital, with primary retinopathy, which cannot be distinguished from typical retinitis pigmentosa. When we do ERG, it will be found to be abnormal to undetectable. And why we should identify it? Because we can manage the deafness, at least the deafness can be managed through cochlear implant. Kearney-Sayre syndrome. This is not our first time to mention the Kearney-Sayre syndrome. We mentioned it in the neuro-ophthalmology. We said that it is a mitochondrial disease that is characterized by pigmentary retinopathy, chronic progressive external ophthalmoplegia, ptosis, and the most important is the cardiac conduction defects, which are the cause of death, and also cerebellar ataxia. The muscle fibers, muscle biopsy will show the rigged fibers by light microscopy. Another disease called the Revson disease, which can be either infantile or adult onset. This is an autosomal recessive disease characterized by pigmentary retinopathy, peripheral neuropathy, ichthyosis, cardiac conduction defect. ERG responses are severely abnormal or undetectable in all ages. And the distinguishing feature here is the high phytanic acid. They will have high phytanic acid in the blood and urine. So after diagnosis, we can manage or prevent the deterioration by restriction of the dietary phytanic acid. So this will be a line of management. Wherever or whenever there is a material which is responsible for deterioration, restriction of this material will be helpful. Like here in Revson disease, the restriction of phytanic acid, like as we mentioned before in cystinosis, restriction of the cysteine. So this will be helpful to control the disease. Bardet-Biedl syndrome. This is an autosomal recessive disorder characterized by pigmentary retinopathy, polydactyly. Those patients have extra fingers. So please don't forget those patients who have extra fingers in the exam with a photo of pigmentary retinopathy, or if it is a scenario of a patient with pigmentary retinopathy with extra finger, with congenital obesity, mental retardation, and hypogonadism, this is a Bardet-Biedl syndrome. Okay. So all these will cause retinitis pigmentosa, which is one of the causes of night blindness. So Other cause of night blindness apart from retinitis pigmentosa will be other dystrophies like gyrate atrophy, choroideremia, vitamin A deficiency, congenital stationary night blindness, and zinc deficiency. We are still going through other causes of night blindness with pigmentary changes, like the next one is called A-beta lipoproteinemia. A-beta lipoproteinemia, the other name is called the Batten-Cormick syndrome. This is a syndrome characterized by enzymatic deficiency. This enzymatic deficiency will cause depletion of vitamin A in the liver and the retina. We know that vitamin A, the major resources for vitamin A are present in the liver and the retina. This enzyme will cause deficiency in the vitamin A. So we know that vitamin A is responsible for healthiness of the retina. So those patients will have night blindness with retinal degeneration and pigmentary changes due to vitamin A deficiency. And there will also be white dots present all over the fundus, more numerous periphery, these white dots. So giving a retinitis pigmentosa-like picture. Sometimes some of those patients can develop angioid streaks, and other manifestations can be ptosis, ophthalmoplegia, strabismus, nystagmus are less common findings. Another disease that we just mentioned is the rhizome disease, which is due to overaccumulation of the phytanic acid in the cells and tissues. It will result in night blindness, pigmentary retinopathy, peripheral neuropathy, and ataxia. They will show some iris atrophy, hypoplasia of the iris, and the characteristic feature is the presence of dysplasia of the feet and short stubby thumb. This occurs in the adult onset rhizome disease, which is which gives the picture of the short stubby thumb appears like that of the Weill-Marchesian syndrome. Another disease also belongs to the retinitis pigmentosa-like disease, which is called the Batten disease. Batten disease is an autoimmune disease characterized by the juvenile onset and rapid onset of visual loss with seizures, ataxia, and psychiatric symptoms, with visual loss, night blindness, photophobia, loss of peripheral and color vision. Another disease that it is not very typical like the retinitis pigmentosa, so it will not cause a visual loss, or sorry, not cause night blindness, but it is one of the retinal degenerations. So it's called Aicardi syndrome. Aicardi syndrome, it is a disease characterized by or occurs due to absence of corpus callosum. Corpus callosum, where the communication between the right and left hemispheres of the brains occur. So those patients usually present with infantile spasm, and then there can be involved into a variety of medically refractive seizures. So here is the presentation. You present with the spasms, and regarding it will cause also intermittent ataxia, giving the picture of Guillain-Barré syndrome. The characteristic feature, this fundus photo appeared before in the exam, it will show multiple chorioretinal lacunae. These lacunae are bilateral, rounded, non-elevated, with the vessels cross over their surface. Other manifestations include the ptosis, the coloboma of the optic disc, optic nerve, microthalamus, pupillary membrane, iris colobomas, choroidal colobomas, morning glory disc, retinal detachment, nystagmus, and 6-nerve palsy. Okay. Another disease of retinal degeneration, which also can cause nyctalopia or night blindness, called the enhanced Iscon syndrome, with another disease of also its spectrum called the Goldman-Favre syndrome. Enhanced Iscon syndrome and the Goldman-Favre syndrome, both of them represent the same spectrum, but with the Goldman-Favre is more severe. It is an autosomal recessive disorder characterized by nyctalopia or night blindness in childhood, with sometimes hemeralopia. Hemeralopia meaning that there is a reduced vision in the bright light. There is pigmentary changes which are more concentrated at the arcades or at the mid-periphery, and will be associated with advanced cases by the round pigment clumps like that. The macula can be involved by cystoid macular maculopathy and the schisis of the macula or foveoschisis. Also, it is a degenerative disorder, so there could be a vitreous degeneration. Peripheral retinoschisis can occur. Okay, so these are for the retinal degenerations. For the choroidal degeneration, there is a disease called the choroideremia, which is characterized by choroidal blood vessels degeneration. This also appeared before in many exams, especially the advanced ICU exam. This is a disease which characterized by progressive visual loss, usually starts from the first to second decade, and usually affect the males. Usually those patients present in the first decade by the night blindness, and as they grow in the second decade, they will complain more of a peripheral field loss, and by the fifth decade, they will lose their central vision. So there will be like peripheral encroachment over the fovea, which will be preserved until the late of the disease. The earliest manifestation of this disease is the presence of RPE clumps. You see here, this and this and this. These are widespread RPE clumps. Then there will be areas of atrophy, choroidal blood vessels atrophy, with the appearance of the sclera and only large choroidal blood vessels. So see here, these are the retinal blood vessels, and there will be larger choroidal vessels are apparent, and this whitening is the whitening of the sclera. The whitening of the sclera, which was obscured by the choroidal vasculature, it is no longer present in the choroideremia. So this disease starts by night blindness, and then it will be present until the late disease. The central island of the fovea will be affected. Dr. Hager said it will be like albino fundus. Yes, it's more or less. So albino fundus will be more depigmented, but they have normal blood vessels, and they could have hypoplasia of the optic disc and of the fovea. Another interesting disease belongs to the retinal degenerations and dystrophies is called the Oguchi disease, and also it was asked before in the exams. So Oguchi disease means that when you check the patient in the light like that, you will find that there is a golden metallic sheen. The fundus is glowing. However, if they left the patient in the dark, the fundus will return to the normal. So the yellowish metallic sheen of the posterior pool is essential for diagnosis. With prolonged dark adaptation, if the patient is stayed at the dark, then the yellowish fundus becomes normal. When the patient is re-exposed to the light, then there is a golden yellow metallic sheen. This phenomenon is called the Mizu-Nakamura phenomenon. Sometimes some resources say it is called the Mizu phenomenon or Mizu-Nakamura phenomenon. This occurs due to abnormal dark adaptation or no abnormal adaptation of those patients. So they have abnormal rods, they will have night blindness. This is one of the causes of nyctalopia or congenital stationary night blindness. Another disease of the vitreoretinal degenerations is called the Stickler syndrome. And Stickler syndrome is characterized by abnormal collagen. So they have abnormal gene. This abnormal gene will result in abnormal production of collagen. This collagen present in the eye and present also in other structures of the body. So this will result in abnormal maxillofacial or maxillofacial anomalies, ocular anomalies, auditory anomalies, and joint manifestations. This disease can be autosomal dominant or autosomal or sporadic. So regarding the eye, what is the characteristic features of the eye? The most important, it will be the presence of, or let's say not presence, it is the absence of vitreous. Those patients will have vitreous degeneration or vitreous syneresis. So the vitreous will be in the form of membrane or beaded configuration. So this photo appeared before also of the ICU exams. There is vitreous syneresis or membrane. The vitreous is becoming empty. This is sometimes referred to as empty vitreous. When you do ultrasound for those patients, there is no reflectivity from the vitreous. So the importance of this disease also that there is radial perivascular retinal lattice degeneration. So these are called lattice degeneration. They are arranged around the blood vessels, and they are radial and perivascular. Both of the vitreous syneresis and radial perivascular lattice degeneration are almost universal. They almost occur in every patient. Okay, so the importance of this disease that it should be recognized, because if we recognize this disease and we do prophylactic treatment of the peripheral retina using 360-degree cryotherapy or circumferential laser, this will be effective to decrease the risk of retinal detachment in up to 50%. So those patients should be managed by peripheral laser retinopexy to avoid retinal breaks and retinal detachment. Okay, so these are for the retinal and choroidal dystrophies. Let's now talk about the macular dystrophies and the macular lesions. So starting by what's called bullseye maculopathy. Bullseye maculopathy is a lesion in the macula where the central area of the fovea appear dark, surrounded by a hypopigmented area, surrounded by darker areas. So the center of the macula will be like like resembling the bull's eye, with a central dark area surrounded by hypopigmented area. What are the causes or the etiology of the bull's eye maculopathy? There are some ocular diseases such as cone dystrophy, Stargardt disease, age-related macular degeneration, and Leber congenital amaurosis. Remember Leber congenital amaurosis that we spoke about in the MSQ lecture in the pediatric? Leber congenital amaurosis. Or the systemic features like Bardet-Biedl syndrome, the one which is causing retinitis pigmentosa-like picture. Or very, very important condition, which is very, very frequently asked in any exam, called the hydroxychloroquine and the chloroquine toxicity. So what are the chloroquine and the hydroxychloroquine? These are the anti-malarial medications, anti-malarial drugs, and also can be used for management of patients with rheumatoid arthritis. So those patients may show drop of vision, and because of the deposition of this drug into the macula, it will show bull's eye maculopathy, and it will show increased macular pigmentation, arterial narrowing, vascular sheathing, decreased color vision. So those patients need to work up by EMS or GRID, ERG, EOG, electroretinogram and electrooculogram, visual field, and check the cornea for what? Can you tell me why should we check the cornea for patients on chloroquine or hydroxychloroquine? Yes, exactly, for the vortex keratopathy. So always check those patients for the presence of vortex keratopathy. Okay, so let me tell you more about how would we manage patients with chloroquine toxicity or hydroxychloroquine toxicity with more details, because in the last years I found that the question about them are asked more frequently in patient in candidates applying for the FRC of the exams, but also FRCS and ICO exams are asked as well. So I'm speaking about the Royal College guidelines on hydroxychloroquine and the chloroquine retinopathy. What are the recommendations on screening? There are very solid criteria for screening and for management, depending on very solid factors. So please concentrate with me. Who should be screened for chloroquine and hydroxychloroquine toxicity? Annual screening for patients who have been taking hydroxychloroquine for more than 5 years. So here is the number. For hydroxychloroquine, if a patient is receiving hydroxychloroquine for more than 5 years, you need to check him. It will be unlikely that it will cause toxicity before 5 years. However, if a patient is receiving chloroquine, then you should examine him or check him much earlier because it is much toxic to the retina than the hydroxychloroquine. So you just need to check him for 1 year. After 1 year, then this is the threshold for checking a patient with chloroquine toxicity. Annual screening for patients taking hydroxychloroquine less than 5 years who have been at additional risk factors for retinal toxicity. Like if the patient is on concomitant use of tamoxifen, or which can cause macular crystals and toxicity, or if the patient has impaired renal functions, which will be causing more accumulation of hydroxychloroquine within the body, then those patients should be examined much earlier than 5 years. Okay. It is the responsibility for the prescribing physician to refer the patient eligible for screening to the local health eye service. So what are the baseline screening examination? If you are now seeing a patient who is on hydroxychloroquine for more than 5 years or chloroquine for more than 1 year, what should you record? First of all patients planning to be on long-term therapy more than 5 years for hydroxychloroquine and more than 1 year for chloroquine. This will be the patients who will continue to use these drugs. It should be ideally performed within 6 months from starting hydroxychloroquine or chloroquine, but it can be within 12 months as well. What should you do? You should do fundus photograph, spectral domain OCT, Humphrey central perimetry or microperimetry of the Humphrey visual field 2 if the macular pathology is present. Okay, so you should record fundus photography, Dewey OCTs, and the Humphrey visual field. Okay, so all patients should have central perimetry or microperimetry and spectral domain OCT and the fundus autofluorescence. Multifocal ERG should be performed in specific occasion when there is persistent and significant visual field effect that is consistent with hydroxychloroquine retinopathy, but you can't find any structural changes in the spectral domain OCT or the fundus autofluorescence. So multifocal ERG is an adjuvant tool used for supporting your suspicion of presence of abnormality or toxicity, but it is still not obvious in the fundus fluorescein angiography or a fundus autofluorescence or the spectral domain OCT. Okay, so we do now, let's count central visual field, OCT scan, fundus autofluorescence, multifocal ERG. Let's now interpret. How would we interpret these investigations? No toxicity, meaning that there is no abnormality in any test. If any test doesn't, if there is no test showing any abnormality, then there is no toxicity. Possible toxicity if there is one test showing typical of hydroxychloroquine retinopathy, but typical abnormalities are not present in other tests. Definite toxicity is when there is two test results, one subjective by the patient and one objective like multifocal ERG, with abnormalities typical for hydroxychloroquine retinopathy. Okay, no toxicity, no signs, no signs in any test. Possible toxicity, then there is one test showing a typical. Definitive toxicity, two tests showing the typical manifestations, one subjective and the other is objective. So how would we manage a patient with possible retinopathy and how would we manage a patient with definitive toxicity? For the possible retinopathy, we can still continue the drug treatment. Right? So check here for the MCQ. We can still continue the drug if a patient has possible retinopathy. So patient with one abnormal test result on the retinal imaging by the OCT scan or fundus autofluorescence, but they have normal visual field, then they have abnormal anatomy, but normal physiology, normal function. Then they should return for annual review. Just discharge the patient and they come next year. But the patient who has abnormal function by the abnormal visual field and the normal anatomy, then this should be suspicious. Again, if a patient has abnormal visual field with normal spectral domain OCT, and fundus autofluorescence, then you should refer for multifocal ERG to confirm. And treatment should continue. You start the treatment until the outcome of the multifocal ERG. So the patient will continue on the treatment of the drug until we know the result of the multifocal ERG. So what will be the management of patients with definitive toxicity? The recommendation is to stop the hydroxychloroquine should be made only or should be made to the prescribing physician. You should send a referral note to the referring physician or the prescribing physician that we need to stop the hydroxychloroquine, but you don't stop it by yourself. The ophthalmologist shouldn't stop the hydroxychloroquine by themselves. And the patient should be referred for appropriate support for hydroxychloroquine retinopathy, like low vision or eye clinic liaison officer, like certification of visual impairment, referral to charities, and the patient should inform the driving vehicle license authority in the UK that to be advised not to drive until they have instrument visual field test confirmed that it is legal to do so. Termination of screening, the screening should be discontinued if the patient stopped taking hydroxychloroquine. So if this is like dose dependent, if the patient stopped that treatment, then no need for screening. Okay, easy. Please remember that for the exam. Another macular dystrophy called the cone dystrophy, which is one of also the differential diagnosis of bullseye maculopathy. So those patients will have usually sporadic, or it can be autosomal dominant or X-linked recessive. Those patients will present usually in the first to the third decade with diminution of vision, which mainly occurs at daylight because it affected the cone, not the rods. So this affected the cone. Clinically, you will appear with the bullseye macular lesion and very late with geographical macular atrophy. The ERG will be photopic or showing reduced photopic and normal scotopic. Remember from the investigation lecture last time. Those patients will have abnormality in the cones, not in the rods, with guarded prognosis. So the most important macular dystrophy will be the Stargardt disease. Stargardt disease is the most common hereditary macular dystrophy. So this will be the most common. It will be inherited as autosomal recessive, and those patients present usually from the first to the second decade of life. I saw some patients or many patients of the Stargardt disease where the parents are saying that the child is malingering, and he says that he can't see at the school. And when you examine him, you found that there is nothing abnormal. So you suspect also as a child is malingering, but you have to have a strong index of suspicion to be able to diagnose the Stargardt disease. So for many of those children will have apparently normal fundus, but for others, they can show the typical Stargardt disease lesions, which are called PC-form flecks. They will appear as flecks, yellowish white flecks present at the level of RPE. There will be beaten metal appearance of the fundus, foveal atrophy with the bullseye maculopathy. Also, it could have an RPE abnormality or degenerations in the form of salt and pepper retinopathy. So the diagnosis here will be with the fundus fluorescein angiography. Those patients, they have these PC-form flecks, they have lipofuscin causing blockage of the choroidal fluorescence. So the blockage of choroidal fluorescence will result in what's called silent choroid. Silent choroid is a very important sign for Stargardt disease. Also, they can lead to atrophy of the retinal pigment epithelium, so it can be also associated with window defect at the site of these RPE, at these PC-form flecks, also with bullseye maculopathy. So these are the signs of the Stargardt disease. ERG can be reduced in the advanced cases, and the prognosis is poor. The twin of Stargardt disease is called the fundus flavimaculatus. This disease is also autosomal recessive, but the difference is that it will present in the fourth to fifth decade. So it will be the older version of the Stargardt disease. Clinically, those patients will have bilateral PBC-form lesions at the level of RPE and RPE abnormalities with macular degenerations, but those patients have better prognosis as the central vision is preserved until the late of the disease. So fundus fluorescence angiography will show flecks are hyperfluorescent due to RPE atrophy. So as we know, RPE atrophy will cause a window defect, and the background will be black due to silent choroid. So there will be absence of the normal grayish appearance of background in those patients. ERG also will be reduced in the advanced cases, and the prognosis is good in most cases. Okay, so the difference between the fundus flavimaculatus and the Stargardt, this appears in the fourth to fifth decade, while in the Stargardt will be in the first to second decade. The fundus flavimaculatus will have good prognosis, while the Stargardt will have poor prognosis. Okay, the second most important and most common macular dystrophy is called the best vitelliform macular dystrophy. So what is the best disease? It is unlike the Stargardt disease. It is autosomal dominant, unlike the autosomal recessive Stargardt disease. It affected the males more commonly, like 3 to 1. It has been associated with strabismus and hyperopia, and those patients will have a progressive onset. We usually start in the first decade of life with progressive course. So what is the problem of this dystrophy? Those patients will have macular dystrophy at the level of retinal pigment epithelium in the form of exudation. So you see here this characteristic lesion, this form of exudative central macular detachment with the pigmentation can occur in the end stage with atrophic. So this disease, strikingly, this disease can present with a massive fundus lesion or massive macular lesion with very good visual acuity. Like this patient could have visual acuity of 6/9. So when you see him for the first instance, you would expect that this patient have very poor visual acuity, but it is unlikely. So usually it will present in younger age group, and it will be the visual effect is minimal. As the disease is progressing in the later stages, where the macula become atrophic or there is a CNV is developing, then at that level, the patient will have poor visual acuity. So let's see what are the stages of the best disease or best vitelliform macular dystrophy. At stage 1, it will start by what's called pre-vitelliform stage. There will be just small, rounded, submacular yellow dots with very subtle RPE changes. So this is stage where before the yellowish lesion appear. So those patients will have normal vision. Then the patient will proceed to the stage 2, which is called the vitelliform stage. In the vitelliform stage, the patient will present with an egg yolk or egg yolk-like lesion. So you see the egg yolk? It is due to lipofuscin pigment. The patient will have a central macular lesion which appears as like fried egg. It could be multiple. And when doing the fluorescein angiography, this lipofuscin pigment will cause blockage of fluorescence. So it will cause blocked fluorescence underneath caused by this yellow pigment or yellow lesion. And at that level, also the visual acuity is still good. Then the patient will proceed to stage 3. And in stage 3, you see the hypopion or the egg yolk is now starting to taking a level. So it will making like what's called pseudo-hypopion stage. Pseudo-hypopion stage due to that the lipofuscin is making a level or a layer. And at this level, the RPE is starting to show atrophy. So this will result in doesn't have a picture here. So the RP atrophy will show window defect, and this layer will cause blocked fluorescence. In stage 4, it's called the vitelli-eruptive. Vitelli-eruptive stage, it will appear like scrambled egg. So we don't know what is the problem with egg in this disease, but it will show the scrambled egg stage. So you see there will be disorganized whitening and yellowish, appears as if it is a scrambled egg. There will be irregular subretinal spots. Usually vision is still usually good. There will be areas of blocked fluorescence due to the pigment and areas of hyperfluorescence due to window defect. In stage 5, here is the stage 5. The animations here doesn't work well. In stage 5, there will be the atrophic stage. That the lesion is starting to show atrophy, showing a scar, and this will result in diminution of vision. So this will result in that the vision usually between 20/100. Sometimes some patients will progress to stage 6. Stage 6 is where the patients can develop choroidal neovascularization, or CNV, and this occurs in 20% of patients. Okay, so stage 1, pre-vitelliform, stage 2, vitelliform, stage 3, the pseudohypopyon, stage 4, the vitelli-eruptive, stage 5, the round chorioretinal atrophy. So these are the different stages, and this is the fundus autofluorescent picture. So you see this is here is the OCT showing that the lesion is showing autofluorescence. So the lipofuscin pigment can show blocked fluorescence in the fluorescein angiography, but can show also fundus autofluorescence. Okay, and when we if we are in doubt of diagnosis, we can do OCT scan, and the OCT scan will show detachment of retinal pigment epithelium by accumulation of subretinal material like this and like that. So the subretinal fluid, subretinal material is the lipofuscin. Also, one of the most important investigations in the Best disease is the EOG. So EOG, as I told you last time, will be helpful to detect the severity, detect the carrier state. So even if the fundus looks normal, no structural changes in the macula by the OCT or by the fluorescein angiography, even the carrier state, the EOG will be helpful to detect the carrier state and detect, of course, the diseased patient. Okay, so remember, the EOG is the disease of the egg, the scrambled egg and the fried egg or egg yolk. So don't forget that. Okay, finally, another disease also was asked before is called the incontinentia pigmenti. This is one of the phacomatoses. It was, but for some reason, it is discussed in the retina because of the retinal pathologies. So this disease occurs exclusively in females because this disease is lethal in males. Okay, this was asked before in the MCQs. So how did this disease present? Clinically, the patient will present with a proliferative retinopathy like that of the ROP. So just the only difference is that those patients don't have a history of prematurity, but they will show all manifestations of the ROP, the whole abnormal retinal vasculature, the fibrovascular membranes and detachment, and retrolental membrane. So how can we diagnose it? We diagnose it by the presence of skin lesions. These skin lesions. So what will be the stages of these skin lesions? Stage 1, at birth, the patient will present with erythematous macules, papules, bulli on the trunk and extremities. And as the patient is getting older, at 2 months, there will be the vesicles are replaced by verrucous lesions. Stage 3, between 3 to 6 months, the lesions will take the form of pigmented whorls on the trunk. And stage 4, the skin is atrophic with hypopigmented patches. Okay, So this is the skin lesions starting from stage 1 to stage 4. As I told you that those patients are considered phacomatoses. Why phacomatoses? Because they have skin manifestations, ocular manifestations, and also CNS manifestations. They would have CNS abnormalities like microcephaly, hydrocephalus, and seizures. Could also have dental anomalies such as missing and cone-shaped teeth. And the treatment for those, it will be the same like treatment of ROP. So if it is causing a fibrovascular membrane or a ridge formation or fibrovascular proliferation, we do laser photocoagulation on the ischemic retina. But if this is the picture, like if there is a falciform fold or macular dragging, then the treatment should be by parsoplan vitrectomy. So to just to restore the retina to the anatomical location. Okay. So remember this disease. Okay, yeah. So thank you. This is the end. Let me just see your questions. Okay, so Islam asking about what is the lamellar macular hole. Let me show you again the slide of the macular hole. Okay. Okay, in the lamellar macular hole, you see here, there are full thickness macular hole. But in the lamellar hole, it is, as the name is called, lamellar, so it is not full thickness. So the RPE here is not exposed. You can see here that in the full thickness and full thickness and full thickness, this is a part. This is like still early full thickness. This is a full thickness. You can see that the RPE is exposed. However, in the lamellar macular hole, you will see still there is a tissue of the outer retina. So there is not a full thickness macular hole. This is called the lamellar hole. So there will be the plane of cleavage in the lamellar hole is between the inner plexiform layer and the outer nuclear layer. This is what will result in the lamellar hole. There is also what's called pseudo hole. And in pseudo hole, there is an epiretinal membrane causing a hole in the or the presence of a hole in the epiretinal membrane, but there is no actual disturbance of the retinal layers or the architecture of the fovea. So this is called pseudo hole. Okay, Dr. Atif, the age-related macular degeneration treat follow the MPS study. What is the MPS study? Dr. Kinana, how we measure the size of the hole from the bottom, from the top? It is done by the OCT scan, by the OCT device. So it can measure, you can take measures from the base and the edge, the height and the base, and using certain mathematical calculation, you would know different indices that will be giving you the prognosis of the surgery and the success rate. So this is by the device, by the OCT itself. Macular photocoagulation study? No, the age-related macular degeneration is managed by the ARES study, the ARES study. But if you are meaning the CNV, there are a lot of studies. It is, of course, it's out of scope of this. No, CNV, there are many studies. Not macular photocoagulation study will be like an very old study for management of choroidal neovascularization, which depends on the laser photocoagulation. But now, after the era of anti-VEGF, there are like Marina study, like Anchor study, many studies that were discussing the management of CNV. Okay, any question? But let me tell you something. Tell me something that it will be in the exam. In the exam, it will be. It is not. I will not ask you about which drug to choose, but what you need to know is treat and extend profile or treat and extend regimen. Also, the different kinds of drugs or anti-VEGFs. and that the aflibercept is more potent than the anti-VEGF. So if the anti-VEGF or if you are using the Lucentis or Avastin and they are not very useful, you can shift to the aflibercept. Also, of course, all these are results of studies, wide range of studies. So maybe in the clinical trials lecture, my lecture in the clinical trials course, I'm discussing all, of course, most of retinal trials, and Dr. Amin will be discussing the management even in 3 lectures. How would we manage the CNV according to the trials? Okay, so I just wished that we had time to cover that, but unfortunately, we are running out of time. Myopic macular hemorrhage and CNV. What is the difference between myopic macular hemorrhage and CNV? Well, let's first agree on something, that the myopia can cause myopic CNV. Okay, so CNV can occur as a result of myopia. So myopia CNV can be either idiopathic or age-related, or it has a lot of reasons. One of them is the myopia. The second thing, that CNV can cause hemorrhage, as I showed to you, and myopia also can cause hemorrhage. So myopia can cause hemorrhage without a CNV, like what's called Fuchs spot, like submacular hemorrhage, which occurs in myopia. So hemorrhage can occur in high myopia without CNV. And if it is complicated by CNV, it is still can cause hemorrhage. So how would we differentiate by the OCT? So we would know whether this hemorrhage, the source of it is the CNV present, or if there is no CNV and this is just a submacular hemorrhage, which is a complication of high myopia. Okay.